think that there's a lot of data around 3 drug combinations for newly diagnosed fit patients with myeloma. And there is now randomized trial data that suggests that an IMiD, such as thalidomide or lenalidomide, in combination with a proteasome inhibitor, and where we have the most data now is with bortezomib as the proteasome inhibitor, is the optimal combination. There is data now using carfilzomib in combination with Lendex or even ixazomib with Lendex. But those are all phase 2 studies and don't have phase 3 trials yet demonstrating their superiority over the bortezomib, lenalidomide, and dexamethasone triplet. I think that there has been some controversy in the community about whether cyclophosphamide can be added in, oral cyclophosphamide. And what we now know is that cyclo-containing inductions are in fact inferior to IMiD proteasome inhibitor-based triplets. We know that transplant has been one of the first things we did that improved survival for patients with myeloma. And the endpoint that was associated with that improvement in survival is a higher complete remission rate. More recently, when we have better drugs as part of the initial induction therapy and we're achieving complete remissions, the question has been asked, should we delay transplant? Do we even need transplant? And there have been a number of trials from Europe that continue to demonstrate the benefit of transplant, both in terms of remission duration and survival. What I'll tell you is that if you have a high-risk patient and you're going to offer them transplant, it's better to do it early, because if you wait till it's late, you may have already lost the opportunity to transplant them. And while there are questions that are being asked in trials about transplant versus no transplant, the standard of care continues to be to use a transplant after 4 cycles of induction. There was now a large meta-analysis done from the French and the Italians and the US maintenance trials. And in that they demonstrated, with a median follow-up of over 6 years now, that there's a survival benefit for lenalidomide maintenance after transplant. Now, the one group that did not gain benefit from len maintenance was the high-risk category of patients. And we've actually published previously from our group that the 3-drug combination of bortezomib, Lendex, or RVD maintenance actually works quite well for patients with high-risk disease. And so, in my view, maintenance should be tailored to the genetic risk of a patient, which you have to figure out at the time of initial diagnosis. Well, I think that the workup is probably the same as it is for patients who have symptomatic myeloma, but it's important that they undergo some level of risk stratification. And we know that 3 simple tools like free light chain assay, percentage of bone marrow plasma cells, and magnitude of the M protein can separate out 3 very easy categories of patients with smoldering myeloma.